there we go.
Hopefully the question will...
Yeah, the question's on one of the first slides. First of all, good morning, everyone. Before I start talking, I'd like to say thank you for having me here. It's a great opportunity to meet old friends, make new ones, restock on my beef jerky and root beer. And you even promoted me to Lieutenant Colonel on the event program, so I'm flattered. I just hope my superiors will follow up on your suggestion. We'll see about that. I have a question too. Pretty simple. It's difficult to follow up on a talk like that, but I'll try to rise to the challenge. Well, what is the leading cause of disqualification at the German Air Force Department of Internal Medicine for pilot applicants? You got the hydronephrosis, obesity, aortic insufficiency, bronchial asthma, and cardiac arrhythmias. I guess, I don't know if that works now. Okay. Maybe.
22 responses so far. Now they're cooking. 15.
Getting there. Ooh. See whether I can clarify that during my lecture. But yeah, we'll see. I guess you'll be surprised, but we'll find out. Okay, I'll just, there we go. Okay, background, reason why I'm here presenting topic is risk assessment, and risk assessment mostly means screening, and screening has always been a controversial issue. On one hand, training is expensive, it takes time, and especially with dwindling numbers of pilots and financial resources, you need to choose the perfect applicant for the job. On the other hand, screening takes large amounts of time, personnel, and equipment, and you can't always be sure whether there's really a benefit to screening. Some institutions never did screening by echocardiography and sonography, others did and dropped it due to lack of efficacy. And our question at the Institute was, is the way we're doing it still the way we should be doing it, or should we change too? So why are we doing that? We're trying to identify unqualified applicants to avoid hazards to the applicant due to the mission, and hazards to the mission due to the applicant, as well as overall flight safety should be, well, obviously cared about. And especially within the German Armed Forces, we'd like to avoid premature retirement and or disqualification of trained pilots, because it's simply a waste of money put into training, and we don't have that much money left. So it's not just theory. I have 2 case reports indicating why we do that. First one's a flight instructor, F4F Phantom. He was entering the forces in a time where we didn't do routine echocardiographic screening for all the applicants. He got caught when we implemented the echocardiographic screening for the high-performance jets, and he was screened as well, and they found a bicuspid aortic valve. Initially, he had no clinical problems, there was no impact on hemodynamics, but as it is often the case, he progressed into aortic valve fibrosis and leakage, and subsequently got disqualified, first as a flight instructor and later on as a jet pilot too, because he had a further progression. You can see the jet here. Let's see if I can get the mouse working. Is it anywhere? Oh, it's not. Let's see. Well, you could have seen the video if it had worked. Let's see. Yeah, should work. Maybe. Yeah. You can see the red jet here indicating the aortic leakage. Those are his actual echocardiographic images. Other part, this time pilot applicant, 20 years of age, and during the sonography screening, we detected a multicystic kidney on his right side. He as well hadn't had any symptoms so far. It wasn't known until he came to the screening. Blood and urine tests were absolutely normal, and when we found out, we sent, first of all, obviously he was disqualified for flying duty and also for general military service due to the risk of premature retirement following progression of his disease. And we sent him off to special counseling and genetic testing. Those shouldn't be here, just in case you wondered. So there is relevance here. Material methods, it was a retrospective analysis of all the pilot applicants screened at our institute, and the German Air Force Institute of Aviation Medicine screens all the pilot applicants across all branches of service. Time frame was the last 5 years, because at the end of 2006 we implemented an electronic data archive for all of our applicants and all the routine medicals, so that was the easiest to look up without going to the basement and leafing through tons of paper folders. And within those 5 years we had a little bit more than 4,100 pilot applicants screened, not counting ATC applicants and other first-time applicants, but pilot applicants. And we were looking for pilot applicants who either completely disqualified from flying duty or got qualified with restrictions of no rotary wing, no jet, or no Eurofighter. Just some general data, most of them male. Median age was 19. In case you're wondering why we have a 52-year-old pilot applicant, that's for organizational reasons. He had to have the same amount of screening done as a pilot applicant would have, and I didn't take him out of the study because it doesn't really amount to anything percentage-wise. Overall screening results, out of all of those applicants, 92% qualified. 6% qualified with restrictions and only 2% disqualified. And that's overall screening, not just echocardiography and sonography. If we look at the screening results just after echocardiography and sonography, it doesn't change much. So if you look at it the other way, by screening via echocardiography and sonography, we get most of the guys who should be disqualified in the first place. Disqualifying findings. 33% had other disqualifying diagnoses than echocardiographic or sonographic. We'll get to that in a second. But you can see about 60%, more or less, had sonographic or cardiographic findings that disqualified them. And especially echocardiographic findings. Hence, I'm in this session and not in any other one. We had one person with a sonographic finding that got disqualified, and I'll come to that in a second. And the rest just got restricting diagnosis. And if you look at the disqualifying echocardiographic diagnosis or findings, you see that a large part is connected to the aortic valve, either being an aortic insufficiency or a bicuspid aortic valve. This also contains combined valvular defects, and we have a few atrial septal defects and patent foramen ovalis, but clearly the single most disqualifying diagnosis is the aortic insufficiency. And a little remark on the bicuspid one, we classify into bicuspid aortic valves and functionally bicuspid aortic valves. So if it's a tricuspid one with a fusion at one of the rafes, we call it this functional bicuspid, and we might let them fly without a waiver or without restrictions. Sonographic findings, disqualifying. We have the hydronephrosis, or general the urinary tract, and we had one with a rather large liver cyst and one with a polycystic liver who also got disqualified. And we have at least one horseshoe kidney. I have to say the data is compromised not compromised, but there's a little impact. This data was analyzed according to the ICD-10 classification. We also enter in our system following our screening. So I'm quite sure that there are two more people with a horseshoe kidney, but they never got coded into the system, so they didn't show up on the data output, but we're close to that. Restrictions due to echocardiographic or sonographic screening. For the most part, the general restriction of no jet aircraft. Internal-wise, hardly any restrictions concerning rotary wing. We had those with major valve defects where we said, no, not even high-performance helicopters. And Eurofighter, the 18%, that's it's getting more now because we look a bit more closely at the valvular defects, but we'll see about that. Restricting other sonographic findings, you can see here, again, valvular defects, of course, pulmonary, restricting pulmonary valve defects and tricuspid defects, not so much the aortic valve. And you can see here the bicuspid aortic valve again, for two reasons. I talked about the distinction between functionally bicuspid and real bicuspid ones, and also within those 5 years of time frame we analyzed, there's been a policy change. Initially, no bicuspid valve whatsoever was qualified, and then we changed into the functionally and biologically bicuspid valve, so that's why they show up twice. Other disqualifying findings in the internal department, there are the obese. Lucky for us, not so many obese pilot applicants yet. There's a tendency, and probably if we analyze the next 5 years, this number will go up. Unlike our Belgian colleagues, we don't primarily disqualify all pilot applicants with bronchial asthma. We do if they have severe symptoms and they might need a waiver, but in order to completely disqualify, you have to have a full-blown asthma, not just wheezes in the past or a slightly pathologic spiral. And unfortunately, even at the young age, hematology, oncology, we had quite a few with either leukemias or we had one with thyroid cancer and obviously testicular cancer of all kinds of forms, which is the right age group. So yeah, and just 4 months ago we had one pilot applicant with a suspicious thyroid gland in the sonography, and he turned out to have thyroid cancer as well, so we think it worthwhile to screen. Restricting findings, there's all the arrhythmias, severe acne, because we consider that disqualifying or at least restricting, because it might lead to untight mask fitness. So we take that, and Dr. Wohnhaus already mentioned pulse regulation, blood pressure regulation. If they have tachycardial dysregulation or any other symptom like that, they also get restrictions, usually no jet. The title was efficacy. Looking at that, quite simple. It cost the German Air Force around 5 million euro to train Eurofighter pilot to German combat ready. That's a lot of money, and we don't have that many. Our regenerative numbers are around 12 a year. So if we lose one of those, we lose the 5 million, potentially, depending on how far he got along the training, and we lose a hefty percentage of our new pilots. So we want to make sure that we exclude all of those who potentially drop out. And if we look at the number of total examinations at the department, that's around 20,000 in those years, with the pilot applicants only constituting around 20% of the work. So the additional amount of time and money we spend on screening those echocardiographically and sonographically doesn't really impact much on our total workload. So in summary, we think it's worthwhile to continue our screening practice. And that's what the discussion says. We think the echocardiographic and sonographic screening of the German Air Force pilot applicants has a medical benefit because it serves as prevention and sometimes leads to early diagnosis of potentially hazardous diseases or fatal diseases. It is cost effective, at least the way we see it. It is relevant for flight safety because we do find pathologies that can lead to sudden incapacitation, and it is still needed to select the best possible individuals for a flying career within the German Armed Forces. And that leads me back to that question, which I hopefully pointed out extreme enough so everyone might remember it, and I think you can vote again. Oh no, I'm a Major General. It's getting even better. Should keep talking. Oh, what is the vote? Getting there?
Time for a few more. One more, hit 70. Okay. Place it up there.
Let's see. Ah, it worked. Some of you heard the slight remark of mine. Yes, it's the aortic insufficiencies that's the leading cause of disqualification. Restriction-wise, it's others, but disqualification, it's the aortic insufficiency. So that's right. And one last disclaimer following all of what I just said. I'm not a cardiologist. I'm a GP. So any in-depth questions later on the panel, I'll gladly delegate to Lieutenant Colonel Wohnhaus, who's more than qualified as a cardiologist, to answer those questions. Anything else, feel free to ask me. And that's it.